The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Good day to all of you. I am Tony Urbanek, and we are here gathered for the next episode of TMD Demystified. I look forward to my presentation today, and hopefully you can get something significant from it. Title of today's episode is Dentist as TMD Physician, or let's call it TMD. Let's call it Dentist as Oral Physician. Dentist, changed the title already. Dentist as Oral Physician. This will apply to TMD for sure. In fact, it definitely applies to TMD. Obviously, one would think that if you really understood TMD, the jaw joint, everything having to do with it, the cause of TMD, the solution for TMD, everything that is related to TMD, that you need to know a lot about the body. This is not the mouth, obviously. And what my experience has been is with most dentists in our community, my experience in Middle Tennessee as an oral maxillofacial surgeon, and dealing with hundreds and hundreds of dentists throughout my career, for the most part, dentists are almost 100% focused on the mouth. And almost 100% of the time. And everything having to do with the teeth and related structures having to do with the teeth. Fortunately or unfortunately, the understanding and treatment of the temporomandibular joint is well outside the location of the oral cavity, and takes a much broader and deeper understanding of the function of the human body than just what's going on inside the mouth. As I went through dental school, it became rapidly apparent to me that distinction and deviation, even in my own class, way back in the class of 1973 of Indiana University, and that as we went through the first 2 years, I could see obviously that the vast majority of my classmates, as we went through the different medical sciences, basic sciences of anatomy, physiology, biochemistry, these topics were just a stop and a barrier to overcome so that they could get into the clinic. I think I might have mentioned in my case, I was just totally different. I was enthralled by what I was learning about the human body and how this might be applied in a more general way to dentistry. And I guess that might explain why I ended up with as an oral maxillofacial surgeon and academic experience and degrees in cell biology and gross anatomy, and why I was a fellow with the NIH in my own research project for 2 years. But that explains me. I'm almost one-off in my class as it related to those interested in the basic sciences. So I was very interested in the basic sciences, which had a large part in my having the interest and the ability to investigate this thing we now call TMD in a very objective and unique way. The point of this hopefully brief presentation is that Fortunately or unfortunately, my colleagues, and I say colleagues, I have colleagues on the medical side, I have colleagues on the dental side, I have colleagues on the academic side. But fortunately or unfortunately, only those colleagues with a basic understanding of dentistry, dental school, and what you learned in dental school have any chance of adequately treating TMD with the simple urbanic device and protocol, because you need the basic understanding of impressions and occlusion and the difference between centric relation and centric occlusion, which are fundamental to using an intraoral device for whatever reason. And so, say that another way, my medical colleagues without basic dental instruction and experience have no opportunity to use this device and protocol. They can't get trained in it. They won't understand the basics and the experience of just doing the simple dental steps, the dental steps of treating a patient with this problem. So we are limited in discussing the use of the device and protocol only with my dental colleagues, which is fine, which is good. On the other hand, my dental colleagues haven't been interested in, from the point of dental school, in keeping up with and understanding or in remembering, and I don't expect everybody to remember what they learned in dental school, that is for sure, but have an interest in those things we call the basic sciences: anatomy, physiology, biochemistry, which leads us to the important features to understand about TMD, which is, how the autonomic system works, how inflammation works, how the immune system works, the gross anatomy of the muscles and tendons and nerves in and around the head and neck, So I'm just painting the background, the structure here of why I named it this way, the dentist as oral physicians. And I would hope that those interested in treating TMD consider themselves and educate themselves more in the arena and along the lines and consideration that they are the physician of the oral cavity and related structures. And when you're treating TMD, you really are, because you have to understand a lot about these disparate symptoms that are treated most often misunderstood and misdiagnosed and misdirected by the physicians. I mean, another way of saying this is, if you're treating TMD correctly according to the use of our device and protocol, you are the physician in charge, and need the full understanding of what you're doing and how it works and the things you need to do to make it go correctly. I've been through the laundry list of symptoms many times on these episodes and in our course that are directly related to inflammation within the temporomandibular joint. So let's just start out by saying, if you're going to be the physician of the oral cavity and treat TMD, you need to know a little bit about inflammation. You don't have to know a whole lot, and there is a lot to learn. There is a lot that still needs to be learned. We do not know everything that we need to know or there is to be known about inflammation. I still maintain that sooner or later we are going to solve the problem of cancer basically through our full and complete understanding of inflammation, because inflammation is nothing more and nothing less than the body's response to damage of any kind: cellular damage, mechanical damage, damage due to microorganisms, but all of them create inflammation. And I know you all studied in your basic in your basic pathology course in dental school about inflammation. But I would direct anyone who is interested in understanding TMD to spend just a little time. And I direct people to Wikipedia. There's a great review article on Wikipedia on inflammation, capital letters, inflammation, great review article. Don't have to memorize it, but it covers the waterfront, and it kind of gives you an understanding, a general understanding and appreciation. It's more about appreciation. I may not understand it all. It's a complicated process, set of circumstances and data, but it just gives you you read it through and you have an appreciation of what inflammation is all about, how broad it is, all the different segments. You don't have to memorize it, but it gives you that appreciation. Very, very important. At which point then you begin to become the physician of the oral cavity and related structures. And this is a medical problem, by the way. I made that very clear. When I do surgery, or when I did surgery, I don't do surgery on the temporal. In fact, I don't do any surgery anymore. I just pulled the plug on even office surgery this past week. I pulled the plug on hospital surgery a few years ago, about 4 years ago. I finally said enough is enough. And just last week, I said enough is enough about office surgery, dental implants, extractions, impactions, et cetera. And totally dedicated to our device and protocol and company, TMJ Services. But those of you who consider treating this is a medical problem. When I did surgery on this 2,000 times, these structures, it was always covered under medical insurance. And medical insurance doesn't determine what you are, that's for sure. And there's some debate, and there's definitely some confusion about that beginning years ago. There's dentists, there's physicians, they have different codes. My opinion is that should have really never been that way. Maybe for convenience, it ended up that way. But there should be one code system. And if you're a dentist, then you can use the same set of codes, but put a D in front of it. Or if you're a physician, put a P in front of it, or whatever. But the point is, by convention, now we have two sets of codes, and insurance companies pretty much control who does what, when, how much, whether you can do it or not. And so you as a dentist can, first of all, legally and appropriately, according to your license, treat the temporomandibular joint, which is only considered a medical problem if you do, whether do surgery or non-surgery things on the temporomandibular joint. It's a medical issue in the insurance world. So back to the title again, being the physician of the oral cavity of the mouth. There's a move afoot in the program from many directions to actually promote this among the population, among the community. The one that I know best is Pacific Dental Services with, I don't know how many offices they have, 700,000, I'm not sure. They have a current program to promote and develop the concept in their offices through their dentists of the oral, or the mouth, better say the mouth body connection. And there's, of course, a lot of connections. We've read and promoted for years the periodontal disease and obviously the inflammation and bony degeneration associated with periodontal disease inside the oral cavity has a significant effect on other areas of the body, including cardiovascular disease, immune diseases. That's still all being worked out. And so I am a strong proponent of that concept that there definitely is an oral mouth body connection, and it has, again, because of convention and insurance issues, have been ignored, misunderstood, not directed in that direction, which should have been and should be. So as I think this thing through and develop a network of dentists who use our device and protocol, it is imperative that we train our doctors who are involved along those lines of basic sciences, or that portion of the basic sciences that they need to know to understand and treat TMD appropriately, simply, non-surgically, and to the great effects that we achieve. Successful outcomes, successful patients. So first of all, you can take this level of understanding symptom by symptom. As now that we've considered, I'd like everybody out right now to just kind of open their eyes and consider that they are a physician of the mouth. You're the mouth physician and related structures. So TMD has this laundry list of symptoms, which include frequent and recurring headache, earache, jaw pain, neck pain, tinnitus, ringing in the ears, subjective hearing loss, fullness in the ears, like you've been swimming and can't clear your ear, vertigo, dizziness, upper shoulder and arm pain and tightness. That would include upper back, because some people include the upper back with it, the way it feels. Arm, hand, finger tingling and numbness, and various types of dysfunction, locking of the joint itself. Those are the well-accepted, investigated symptoms of TMD. And in the course that we have available to network providers, I explain, and throughout, actually in points and throughout this these podcasts, episodes on TMD Demystified, I explain quite a bit of this also, but it's fully covered in our course, and that is how each of those symptoms are directly caused by inflammation within the temporomandibular joint itself. That is why understanding the basics of inflammation, what's going on with inflammation? Is it just a few cells in there that are marching around trying to fix things, or is there more to it? Well, there's a lot more to it. And some basic cells and basic knowledge that we've been building on for my entire career, because I took my initial training in cell biology and gross anatomy way back in 1972. And we haven't finished yet. All right, so what I want to do to kind of drive this home is to take this symptom by symptom and go through really how you, in your consideration of let's just say you totally understand the anatomy, physiology, biochemistry, pathology of the temporomandibular joint and related muscles, nerves, and structures. Let's just say you totally understand it. I know it pretty well. I don't claim to totally understand it, but I do claim to understand it pretty well. And so let's take it by symptom to symptom. First one, which really deserves most, I may not spend as much time as it should, or I may overdo it, but headaches. Headaches, it has been forever the area that is treated by physicians, neurologists, PCPs forever. And as we find out that a vast majority of a vast number, I don't want to say majority because I can't prove that yet. Can't prove that yet. I mean, we're going to try to prove it, but a huge number of headaches are not classified as migraine headaches, which is actually a dumping area. The word migraine is badly misused, misunderstood, and really is used by everybody, patients and doctors alike, is somebody who has bad headaches. And then they subclassify it into cluster headaches and morning headaches and morning here and there. What I know, and we know who do our service, is that a vast number of people who come in with a bona fide verified diagnosis of migraine headaches are caused by inflammation within the temporomandibular joint. And when you make that inflammation go away, their headaches go away, whatever you call them. I just call them bad headaches. We treat TMD inflammation and we treat bad headaches. We don't treat migraines. Now, because a lot of those people are misdiagnosed, mistreated, don't have migraine headaches, they have TMD headaches, we make their bad headaches go away. But I think my point is obvious. If you as a dentist can routinely, and you would, and you will, routinely make a huge number of your patients' headaches go away by treating their inflammation within the temporomandibular joint, well, you are classified as a dentist. You look on the wall and your license says dentist, but are you a dentist or are you a physician of the mouth and oral cavity and related structures? I claim that you are a physician. You're a dental physician. In the Eastern universities give DMDs, Midwestern and Western universities, dental schools give DDSs. I have a DDS. They're the same. You get the same training. You get the same. And they chose those two monikers, I think, to highlight maybe in some schools the relationship of the oral cavity to the rest of the body, which kudos to them. But headaches are huge in our country. I think the majority of women I know complain at one time or another of headaches. How many of them are caused by TMD, I do not know yet, but we know and actually have been, our study is out now, which shows a huge and verifies analytically, statistically, that patients with bad headaches that have been classified as migraines diminish and go away when you treat the inflammation of the temporomandibular joint as a physician of the mouth and oral cavity. The next, I think, would be earaches. By the way, earaches and ear pain is not the second most common symptom of TMD. The most common symptom of D is headaches. The second most common symptom of TMD is neck aches, upper shoulder and neck pain. The third actually is a kind of almost close between ear pain and jaw pain. They kind of run together. But let's just say that the next is ear pain. Ear pain is nothing more, nothing less than inflammation within the temporomandibular joint that spills over into areas that can recognize that inflammation and cause pain. And the closest area is the posterior aspect of the glenoid fossa temporomandibular joint is next to the external auditory canal, and the inflammation penetrating that area and penetrating near the subcutaneous layers, which will stimulate pain. And that is why patients will frequently call it deep ear pain. They usually, a lot of patients say deep pain in my ear. And the pain is not coming directly from the inflammation. Well, it's coming from the inflammation, but not from the inside of that joint itself. It's coming from the inflammation that got outside of the area of the joint and finally penetrated toward the external auditory canal. And they will go to their ENT doctors. First, they'll be treated at the walk-in clinics, who will give them antibiotics. If they don't have an infection, but they will get antibiotics for their ear pain. And when they go back a time or two to the walk-in clinic, and the nurse practitioner will shake her head and go, you need to either see your PCP or you need to see your an ENT. And let's just say they go back to the PCP, and the PCP looks in their ear and he goes, I don't see the tympanic membrane swollen. I don't think you have an infection. I'm going to give you some steroids. And give them some steroids, and that works for a couple weeks or a week or 3, and it finally wears off, and then they start having pain again. And then either the walk-in clinic or the PCP sends them to the ENT, and the ENT is more self-assured, self-aware, and he will look inside the external canal, and he'll see that the tympanic membrane is not swollen. No, you do not have an infection. Run them through some tests, maybe get a CT scan or an MRI, and other things. And after a while, whatever their drugs and treatment are not effective. And more often than not, here in Middle Tennessee, because we have a well-known process going reputation, then the ENT will finally say, well, I think this might be a jaw joint problem. And most of those end up in my lab in our practice. But again, when you can recognize it early, you as the dentist can actually, you don't even have to be able to look in the ear. I mean, that'd be nice. I mean, you could learn to use an otoscope. It's super simple. Buy yourself an otoscope and look in the ear. You can tell whether the tympanic membrane is swollen or not, but I wouldn't even recommend that. You don't have to wear, something around your neck that says I'm a physician. You don't have to have a stethoscope. You can be the physician without the stethoscope or the otoscope. And if you do this maneuver and it hurts, there's inflammation. And as a physician, you have made your diagnosis. And as you do that, you can skip all those intermediary steps and all that expense that goes along with it. So the next one is neck pain. They may start out at their chiropractor. They may start out at their PCP. They may go to an orthopedic surgeon. I know we have documented people who have neck pain directly associated with inflammation in the temporomandibular joint that have had surgery on their neck. That has been documented. And when you make the inflammation in the temporomandibular joint go away, the pain in their neck, which had previous surgery on it, which did not handle that pain, will then go away. So again, opportunity to be a physician. And I don't want to get into details. We talked multiple places, multiple times about how and why inflammation can create muscle in the temporomandibular joint through the autonomic nervous system, which sends out a signal to tighten up. First, you tighten up all your facial muscles, jaw muscles, muscle mastication. Then when that's not good enough, tighten up the entire head and the neck muscles, which creates pain where all of those muscles either the origin or insertion on the bone. That's where the pain is. And then when that is not enough and it goes on long enough, the signal comes down, tighten up the whole upper shoulder girdle, and you can have pain literally in the chest and the pectoralis muscle that can mimic enough pain that people think they're having heart attacks. I've seen that 3 times, documented by patient 3 times, different patients. Or arm, hand, finger tingling and numbness, which is much more common than I ever believed. So that is one aspect of temporomandibular joint symptoms associated with inflammation. And the second is a different mechanism we talked about before, but again, we're talking about actually understanding the anatomy, physiology, biochemistry, and pathology of the body so that you can understand how tinnitus, subjective hearing loss, and vertigo are directly caused by inflammation in the joint getting into the middle ear. And it is. And I had an episode recently where we talked about the petrotympanic fissure, which is literally a highway from the posterior aspect of the glenoid fossa into the middle ear, which allows cellular exudate and fluids I'm not sure that it allows cells, it's cells themselves, but I know that it is large enough and located in the correct direction that will allow inflammatory fluids from the interior of the temporomandibular joint into the middle ear. And when that happens, those structures, those minute and extremely valuable structures that are located within the temporal bone to get stimulated inappropriately, because they're supposed to have certain stimulation, but when inappropriately stimulated, will cause tinnitus, subjective hearing loss, and vertigo. ENT surgeons and doctors, physicians, have a name for these symptoms, and Meniere's disease, by definition, in the literature, in the textbooks, is defined as, Meniere's disease is defined as tinnitus, subjective hearing loss, and vertigo. Those are the symptoms. And the ENT doctors are not aware, they are not aware that those symptoms can originate from inflammation within the temporomandibular joint. I mean, not right now, 2022, February the 15th of 2022. Certainly not 1 in 100, because I am educating the doctors around here, but nationwide, I would say 1 in 1,000 are aware that that well-known, well-accepted diagnosis in the ENT world, Meniere's disease, look it up, can be caused by inflammation from the temporomandibular joint. I did not say all Meniere's disease comes from the temporomandibular joint. That has not been worked out yet. There may be other opportunities for inflammation and inappropriate stimulation within the middle ear by other modalities to cause Meniere's disease. That is possible. I don't know. What I do know is we have seen hundreds of times that when you make the inflammation within the glenoid fossa of the temporomandibular joint diminish and go away adequately, eventually the ringing, the fullness, and the vertigo diminish and go away. Meniere's disease. So you can see, I hope you can see my point here. Again, I may have overdone it, but your opportunity to be the physician in this area where other physicians have been lacking, the neurologists, the ENT doctors, the PCPs, the walk-in clinics, they don't recognize it, and you have the opportunity with appropriate knowledge, which is you do not have to dig through the textbooks. I've already done that for you. All the information is in our course. All the information, or most of the information, is actually on these episodes within the podcast. I've covered this all very thoroughly. But today I really wanted to make this point to my dental colleagues about taking the responsibility, stepping up and looking at it. It's just a matter of viewpoint. I mean, again, you don't have to wear the stethoscope and you don't have to, put on the appropriate wardrobe. You are the physician and can be the physician and treat these things that the physicians, my physician colleagues, are not recognizing and inappropriately treating. And all it takes is just a general understanding of the anatomy, the neurology, the biochemistry, the cell biology, pathology of these structures, which are outlined. I've already done the basic work outlined in our course and in our materials. And you can do this, fortunately, without drugs, without surgery, and with the use of a protocol. Most medical doctors have, whether they're using drugs or whether they're doing surgery or whatever they're doing, well known to me, they have protocols for everything. This is our protocol to do this. You take this and do that, and then next you do this, do that. Well, the protocol is very simple. That's outlined well, but the point is you can do this great service for patients. They love you a lot when all these symptoms go away. without drugs, without surgery, and using a physician type protocol, a little intraoral device and some knowledge. I think I made my point. I appreciate, hopefully, I've impinged on a few of you. As always, I encourage comments, even criticisms. I'm always open to communicate. I can be reached at Tony Urbanic at tmjservices.net. You can communicate with our Director of Marketing and Education, Naomi, at tmjservices.net. One of the interesting things, I do these, I record these episodes once a week, and I wondered how long this would be before I kind of ran out of topics. And it is amazing to me that as I go through my week, mostly stimulated by comments or experiences I've had with patients, or thinking about my experience with patients or comments from my patients, for every episode that I record, I have 3 or 4 topics now in the wings, ready to go, because this whole thing is expanding so rapidly in my mind as to the importance of treatment of this, the importance of education to both my dental and medical colleagues, about the great misunderstandings having to do not only with temporomandibular joint, but the misunderstandings having to do with these symptoms that are not well treated at all, which are actually directly coming from the temporomandibular joint, for which you should be the physician in charge. Enough said. I am Tony Urbanic, and this is TMD Demystified. I look forward to speaking with you very soon.